You can see all the presentation, right?
Yes, sir.
Of course, the Bhuvan will also be joining the same panel. So I have one, the 74-year-old lady. So she is actually, though this was shared, I think I have one patient who is going on. I could not prepare that, hence I'm just preparing presenting this case. So 74-year-old lady who's with a good performance status, is a smoker, and there's no personal family history of cancer. She presented with the persistent back pain, painful and frequent urination, hematuria, and weight loss. The underlying comorbidities were osteoarthritis and hypertension. So, so she was investigated for the same. The ultimate diagnosis was the high-grade urothelial carcinoma, which is involving the muscle by 2 RBT, and her hemoglobin was 9, which was slightly low. Creatinine clearance was 75, and she is PD-L1 positive. So the imaging baseline, when it comes to baseline imaging, so Dr. Varun, how do you proceed with this particular patient? So which investigation you are more comfortable with? Dr. Varun?
Yes, sir.
So how do you investigate? Yeah, what do you mean? So how do you proceed with this patient? So this patient, we have the bladder cancer and has got a creatinine clearance of 75, and now how do you proceed? Would you do a PET CT scan, or are you comfortable with only CT scan and a bone scan here?
Clearance is okay. So we have both options. We can do PET scan also. We can go with CT scan with bone scan also. So,
okay.
Most of the time we do PET scan.
Okay, right. So I don't want to waste time, asking others. So this was showing a multiple the lung metastasis, and it was a final diagnosis of urothelial carcinoma with lung and bone metastasis with the GFR of 75, ECOG PS1, and hemoglobin low. Dr. Amitabh, how will you proceed now when it comes to a treatment modality? With this scenario, how do you proceed?
Sir, considering she's elderly and she's diagnosed as a metastatic urothelial carcinoma with lung and bony metastasis, next step will be to assess whether she is eligible or not. You can see she is having a GFR more than 70, and you haven't mentioned regarding neuropathy, so I can assume that she is not having any neuropathy and her cardiac functions are okay. So in that case, she is an ideal candidate for palliative intent chemotherapy with either gemcitabine plus cisplatin plus zoledronic acid, or dosed as MVAC plus zoledronic acid.
Would you feel she'll be tolerating dose done to MVAC in this age?
Yes, sir, definitely, because even the tolerance of dose versus conventional.
Okay.
So there's not much difference, and outcome is obviously better in dose arm.
So which one you do if you're given an option of dose dense MVAC versus gemcitabine in metastatic, which one you prefer?
So GemCis is preferred, considering ease of administration.
Okay. So Samit, is there any different thoughts? If suppose this patient is not platinum eligible, what different would have done in this patient?
So the patient is not platinum eligible. I would go for an immunotherapy upfront for this patient.
Okay.
And that could be either atezolizumab or can be pembrolizumab.
Okay.
That would be my choice of therapy if the patient is platinum ineligible.
Okay. So Sajan there, Sajan.
Yes, Chandra, I'm there.
So if you plan for immunotherapy, would you order PD-L1 status in this patient, or what's your thoughts on that?
So yeah, I would order PD-L1 for this patient, but yes, the first choice might not really depend upon PD-L1 positivity.
Okay. Right. So Bhuvan, if you were to use the immunotherapy versus only non-platinum combination, you have seen that the patient, which one you are comfortable with, immunotherapy or non-platinum combination upfront? Dr. Bhuvan? Not there. Sajan, you can take it. Suppose if you've been asked to whether the patient is not offered, are you comfortable using a non-platinum chemotherapy here versus immunotherapy upfront?
So I'll be more comfortable using immunotherapy rather than a non-platinum chemotherapy.
Okay. So simply because of the tolerance, or how do you place it?
So yeah, tolerance is one issue, and apart from that, I think we don't have any other agent which will actually be I'll be more as an alternative to platinum ineligible patient. Any other chemotherapy regimen which will really work well in this situation.
Okay. Sure. Amitav, any thoughts on combination of immunotherapy plus chemotherapy in the first line? So, what is your thoughts on that?
Sir, what about carboplatin in place of cisplatin? Like, we can do that also or not?
Sir, is this question for me, sir?
Yeah, Amitav. I'll come back to that question, Varun. What you do was, I remember that, and I'll just come back to you later on that. So, yeah, that's for you, Amitav.
Yes, sir. So surprisingly, this combination of chemo and immunotherapy has failed in urothelial carcinomas, in contrast to other lung cancer, other carcinomas.
Okay.
So obviously, my choice will be either immunotherapy or chemotherapy, not the combination one in this setting.
Right. So it's Varun's question. So why not gemcitabine carboplatin? Samit, would you take that? So are you comfortable using the carboplatin in lieu of cisplatin? Samit, not there. Varun, how do you take it? You answer the question.
Hi, can you just repeat the question? I missed it.
Carboplatin in lieu of cisplatin. When do you place it?
I think both are equally good options. If the patient has poor GFR, patient is somebody you cannot give enough of fluids and maybe having an ototoxicity or a neuronephrotoxicity. So I would go for a carboplatin. It's a decent choice.
Okay, thank you. So Varun, where other than that, where do you place it, Varun, by yourself?
Yes, sir, same. Like most of the time, if we can't give cisplatin, so
Okay.
we first give carb, and obviously we can discuss with about immunotherapy also, but we will not emphasize. We start with Gemca. Even there is a problem of tolerance, then we will go for immunotherapy.
Okay, but suppose if the GFR is less than 60 and it's more than 30, that's one more condition where you can use you cannot use a cisplatin, where you can use carboplatin. Now this is what we discussed. The cisplatin based regimens preferred. We discussed about dose length MAC versus gemcitabine cisplatin and gemcarbo. So this all has been discussed, and the preferred regimen in the metastatic setting would be a gemcitabine cisplatin for the valid reasons that we gave. And so if a patient is ineligible, we also discussed about the immunotherapy atezolizumab, which was commented upon, and and a non-platinum combination like gemcitabine influnin, gemcitabine and or gemcitabine taxane. This also was discussed, as we know that in a patient where you use a non-platinum taxane or a gemcitabine combination, sorry, response is to the tune of 40-45%, which is more than the immunotherapy, with overall survival around 15 months, which is almost similar to what immunotherapy. That's the reason why I asked you.
315
So if a patient has cost issues, so immunotherapy, can we use a non-platinum combination upfront, as that shows almost a similar overall survival. So this was the baseline the scan of the same patient with lung nodules. After 6 cycles of chemotherapy, he achieved a partial response. Now, after achieving a partial response post 6 cycle, Amita, how do you proceed with this patient?
Sir, since she has shown a very good response to initial baseline chemotherapy, and considering if finances are not a restrictive factor, then she is a candidate for maintenance with the avelumab as per the data.
Right, I think completely agree. If you would have a progression, for example, after 6 cycle patient has progressed, so what would have been your choice?
Dr. Chandru, I just like to ask the panelists.
Yes,
I have one question.
Okay.
So normally, if it is like platinum ineligible, like first thing is that we make it cisplatin ineligible. But if the patient is platinum ineligible and finances are not an issue, what do people prefer? Because if finances are not an issue, I'll prefer a single agent immunotherapy. So do other panelists also believe the same, or they have some different opinion?
We'll start with Amitabh. How do you take this question? Dr. Surgeon is asking, where if your patient is platinum ineligible, and finances are not an issue, I will go to a single agent immunotherapy. So do other panelists also believe the same, or they have some different opinion? Start with Amitabh. How do you take this question? Dr. Surgeon is asking, if your patient is platinum ineligible and finances are not an issue, I will go to a single agent immunotherapy. would you give a single agent immunotherapy or a non-platinum combination? How do you take it? If a finances are, we'll discuss like finances is not an issue, finances are an issue.
Sir, just now you answered this question because even if you're non-platinum combination or even single agent chemotherapy, the response rate is in the tune of 20 to 30, even 40%, and you can expect a survival of more than a year.
Right.
So I'm not a strong believer of these fancy drugs. So still we can start with chemotherapy and subsequently we can add immunotherapy, even the PS deteriorates. So that's my take, because it's very difficult to use chemotherapy in subsequent line than to use chemotherapy in the first line.
Okay. Dr. Samit? Samit is not there.
Yeah. So my choice in platinum ineligible will be immunotherapy up front. If the patient is non-affording, then I'll have to discuss with the patient probably. With either of the drugs, so that needs to be discussed with the patient.
I think we got this slightly divided house, and Sajjan, Samit, they definitely, I mean, we are given a choice, finance is not an issue, immunotherapy upfront is a better tolerable drug. I just put a question because we had discussed earlier as well. Well, if the response and everything is the same, so why to waste the resources after? That was a contention to ask that question. I think nobody is wrong or right in this particular regard. So start with immunotherapy upfront as you have data to support it, and non-platinum combination because we believe probably it is the same response and the survival. That was the thing. Now coming back to this, if there is a progression or a stable disease, Dr. Sajjan, what would you do in this particular regard? Dr. Sajjan?
Chandra, there's some signal. What is the question?
Okay. If this patient after 6 cycles of chemotherapy has a progressive disease, so in a partial response available maintenance as we have data, if there were to be a progressive disease, how do you take it? Yeah.
So Dr. Chandru, like if because this patient has been first exposed to chemotherapy, which is either mostly platinum based chemotherapy.
Yes, gemcitabine 6/6. This is platinum.
Statin or carboplatin, whatever has, and there's a progression of disease.
Yes.
So I would like to go to second line because if the patient is able to tolerate platinum, then we could either go to kind of a CMV kind of a regimen where we could give 3 drugs, or I could also go to a single agent nab-paclitaxel. So I'll be more happy to go to a chemotherapy depending upon whether single agent or 2 or 3 drugs based upon the patient's performance status rather than go to immunotherapy. Also, one more thing which I like to add is like at that point in time, I also like to have the CPS score. If the patient has got a CPS score which is good, then probably more than 10%, I might be inclined to still use pembrolizumab because these are the patients who might still respond to immunotherapy, irrespective, because we don't have that data with the pembro in the platinum ineligible. So of platinum patient who responded, so or progressive. So these are 2 options which I might explore.
Fair enough. I think I completely agree. So if a patient is progressive second line chemotherapy depending on the tolerance or immunotherapy, so whichever is best. Because what I asked with avelumab, whether the patient has responded or not, it can also be used in the progressive disease because we have a data on that as well. So in only who respond well to chemotherapy, the avelumab has seen some survival advantage. So this is what we had a patient who was given avelumab first line maintenance. We all have cases to share, and this is what the gemcitabine and platinum ineligible combination has resulted in. The 6 months of response with the vinorelbine gemcitabine, and overall response rate was almost 63% of this combination with over a year of survival. This is one more combination of gemcitabine paclitaxel. The response rates of, you can just see, 54 to 70% with survival of 13 to 16 months in the non-platinum drugs. So this is one which just highlight why we should use a maintenance avelumab in the first line instead of using probably the chemotherapy first or a progression. Then I mean, probably this is the reason why it was there. So though their inter-trial combination, the comparison should not be made. The overall, you can see this particular combination has better TFI, the DFI in terms of the survival as well as the PFS compared to other combinations like upfront IO followed by chemo and all that. So this is why the FDA has approved the Pembro and atezolizumab with the PD-L1 as marker in the frontline setting, so where the patient is not platinum ineligible. We need to have, as Surgeon pointed out, to have a CPS scoring to use Keytruda or atezolizumab. So we have still an unmet need in the first line, and then that's when a lot of patients would fail early. Now we have maintenance setting. The maintenance is for avelumab, and this is how the first line, second line things have come up. So the switch therapy, as was talking about, and if a patient progresses on second line, Amitabh, how will you take it if a patient has progression on the second line? Is there anything that you can do?
So theoretically, yes, but practically it's very difficult because two drugs are approved, which are FGFR and another drug which is monoclonal antibody and chemotherapy conjugate. But I don't think either of the drugs are available in India. So theoretically, if the PS is still preserved, we can try with either any third line chemotherapy like this vinflunine or whatever is available versus best supportive care.
And one more thing is upfront metastatic. If there's any FGFR patient, if you do it, or if you send it to us, we have some trial going. Surgeon, it's already on. That trial is on, na? The FGFR in urothelial bladder cancer in the second line.
Dr. Chandru, that trial is not still with us, but yes, very soon we'll have that trial.
Yeah, so that's one thing where we do an FGFR inhibitor in the metastatic UC. If you have any of those patients, they can send us to us.
In fact, Dr. Chandru, I'd also like to add that this is a really fascinating era for FGFR inhibitors, because for Langi also there was a one agent which has got approved. Even here we got FGFR inhibitors approved for us. So correct. I think that's kind of one thing which is on a really fascinating time for. Hopefully these agents come to India soon, but they will get a lot of. In fact, KRAS as well as FGFR inhibitors too. I'm really very excited.
Absolutely. So, Varun, how to take where do you place enfortumab vedotin? It was making a lot of news, and now all of a sudden, I think is it going to stay, or what your take on that particular drug?
Sir, pardon, please repeat the question.
Enfortumab vedotin.
Sir, I don't have any experience with this.
I mean, nobody has it because it is to be imported. So
still, I feel because if there is no other option, and if patient is this particular condition is there, then obviously I would tend to use this drug in these type of patients. But we'll see. But how a patient will tolerate it.
I think we have the evidence for post-second line, where the patient has received prior 2 lines, and then the third line you can use it. It's a good drug to be tried, and this is Javelin trial, which has a survival advantage. One of my patients initially started 7 months down the line. He continues to be in complete remission. He's 70+ years. Carbo he received, and then ultimately he's on maintenance. So how does it matter, Dr. Amitabh, if your patient, you put him on avelumab maintenance? Suppose a upfront patient has gemcitabine, cisplatin, or carbo. Does that matter, or you still use it?
I don't think it will matter a lot, because it is altogether a different drug. Whatever chemotherapy regime you are using, it's not likely to have any significant impact. That's why even the trial is with gemcitabine, the data is extrapolated for approval with dose and Sembec or any other combination of things.
Yeah. So I think, would you use him if you have used upfront non-platinum combination?
That's a clear.
Yeah. I think just out of box questions. Suppose a patient achieved a response and is in complete remission for that matter, non-platinum. Would you use available maintenance or some sort of immunotherapy?
Definitely, yes, sir. If finances are not a concern and patient is ready to accept the thing that there is no data, but he or she is likely to have clinical event.
Yeah. This is what we have asked. So whether you use the carbo or cisplatinum, the advantage is maintained on available maintenance. And think this is what we have done, and then this also we have already answered this question. So So post available maintenance, third line we already discussed, as the panel was talked about the enfortumab and anti-FGFR inhibitor and sacituzumab, which also can be used in this particular line. With that, I come to an end of this panel discussion and thank all the expert panelists for the valued time and opinion. Thank you very much.